So, apologies, it's me again. A slightly different hat on. I have the privilege of being chair of the CMON committee, and just bear with me for 2 minutes, just to remind you a little bit about Felix CMON. He was the son of a Berlin stockbroker whose medical studies were initially in Heidelberg and Berlin, and then he moved to Vienna and Paris. So had a sort of very peripatetic training in Europe. But then he moved to London in 1874, and the fairly recent introduction of the laryngoscope attracted him to ENT, and so he got a job at the Golden Square Throat Hospital and became physician to the Golden Square Throat Hospital, which of course became Golden Square Royal National Throat and Ear Hospital, and moved to Grayson Road. He was, at the time, in the late 19th, early 20th century, one of the most celebrated laryngologists. He attended Queen Victoria, he was knighted, obviously, and he was physician to Edward VII. And he was one of the founding members of the laryngology section of the RSM, so it's one of the reasons the lecture is held here. He founded the International Journal of Laryngology, and after his retirement, a fund was set up to allow an annual lecture to be presented, the CMON lecture. And as you can see, over the last century or so, we can hardly do an operation without talking about some of the people who have given the CMON lecture in the past, some of the most sort of outstanding teachers of the last century, and some of the most inspiring surgeons and teachers have given this lecture. And so following that heritage, it's absolutely fitting that this year's lecturer is Professor Anil de Cruz. It's a lecture that remains to this day, and I think, as Don Harrison wrote in his book, it really is the most prestigious, certainly one of the most prestigious lectures in world laryngology. So, Professor de Cruz, Anil de Cruz, is director of the Tata Memorial Hospital in Mumbai. He trained in Bangalore, moved to Mumbai, and really has been an integral part of the Tata Memorial over the years, maintaining its position within head and neck cancer, particularly competing with really absolutely any other institute, head and neck institute around the world. And its reputation is in no small part down to Anil. He's trained countless head and neck surgeons, going through not only the Tata Memorial, but in his many, many lectures, 150 lectures around the world, nationally and internationally. He's a fantastic teacher, and every time he contributes to a panel discussion, his contributions are always very thought-provoking, very insightful, and you always leave with one or two pearls of wisdom whenever you hear him talk. And just 2 weeks ago, he was elected president of the UICC, so along with his extremely busy job at the Tata Memorial, I'm delighted that he has had the time to accept our invitation to give the 2018 CMON lecture. So Anil, come up and give you a lecture.
Good afternoon, everybody. Peter, thanks for the kind words, and thanks to Peter and John, if he's here, for making this possible. It's really an honor to be invited to give this prestigious CMON lecture. I mean, I always grew up as a young student learning about the Simon's law and the other contributions, and to stand here today in front of you all is really humbling. We went back and forth with emails between Peter, John, and myself on what I should speak about, and we finally honed in on this topic: attempts at addressing the head and neck conundrum in the developing world. I didn't want it to be about problems, talking about GDP, lack of resources, but I wanted to turn it on its head and tell you all on what we've done to overcome the problems that we face when treating patients with head and neck cancer. I bring you greetings from the Tata Memorial Hospital. Some of y'all have been there. It was commissioned by the House of Tata as a philanthropic gesture. This is a big industrial house. You all guys must have heard about it. They do the Jaguar, they have the T, the Taj group of hotels. The government took over this institution in 1962, and we are run by the Government of India, Department of Atomic Energy. And the Tata Hospital is expanding. We've got 5 new facilities coming up in various places across the country. But the cancer care is growing, and it's not only the Tata. The Ministry of Health is probably putting up the biggest cancer facility. For that matter, it's the biggest medical institution that they're putting up post-independence. It's at the National Cancer Institute in Delhi. The Apollo Group, which is a private group, are doing the first proton, and in the next 4 or 5 years, India, which is a low middle income country, will have 4 proton facilities. The Tata Group that started the Tata Hospital where I work are doing a very interesting distributed model of oncology care in the state of Assam. And it's not only tertiary care, they go across 3 levels, changing the entire ecosystem of how cancer care is developed. A kind of a hub and spoke model, which will be unique, and if it works, it will come to the rest of the country. And again, the government is setting up oncology wings in medical colleges, and regional cancer centers across the country are being upgraded. So the pillars that that the Tata Memorial Hospital is known for is service, research, and education. And I'm just focusing on the head and neck part of the service. We have over 9,000 new registrations every year and 3,000 major surgeries. On any given day, if you walk into the hospital, we'll have at least 5 operating rooms doing head and neck. So if any of y'all on that part of the world want to see head and neck, the Tata Memorial is the place to be. 40% of our workload is oral cavity cancers, but just given the sheer volume of 9,000, we see a fair number of larynx, hypopharynx, oropharynx. We don't see the HPV epidemic, which is common in this part of the world, but we see all the other squamous cell cancers. Thyroid isn't again as huge as it would be in this part of the world. Our incidence would be maybe half of what is seen in the US and the UK. Education. 50% of oncology manpower in the country has trained at the Tata Hospital. We have a structured postgraduate teaching program, and this is after people do their basic general surgery or general ENT, come and train at the Tata Hospital on head and neck cancers. We have international fellows, observers, ACEMG accredited institution. Mazin is here, the Oman graduates come to us, the Qatar people come to us. So there's tremendous opportunity for international fellows if they want to come. We take 3 international fellows every year. And we run dedicated workshops every year, and they're focused on oral cancers. There's a thyroid preceptorship course, laser workshop, the GPRA, which is post-laryngectomy voice rehab. And then we do an oncosurge where there's about 3 days of surgical demonstration with live telecast of various procedures commonly done on the head and neck service. And research. India was known for service, but over the years, the number of publications coming from the country and the institution are increasing. I Googled and tried to compile a list of publications on head and neck that have come out of India. And as you can see, the contribution to the world literature is growing over the years, and some of them are quite seminal, and I'll take you through them as we go through my talk. So head and neck is really a cancer of our part of the world. Here is latest Globocan data 2018. And as you can see, Southeast Asia is really the hub of head and neck cancers. About 1/3 of all our cancers are head and neck. And it's primarily because of the way we consume tobacco. Tobacco in India is chewed, the traditional betel leaf with the quid, as you can see. The same ingredients are packaged in a dry form. People who smoke the bidi, which is a crude form of a cigar. So the effects of tobacco are local rather than in the lung. Uh, uh, Many women pyrolyze tobacco on a hot plate and clean their teeth with it. They believe that it's good for dental hygiene. And some of this pyrolyzed stuff is packaged like a toothpaste, and you can buy it off a chemist as well. So it's very, very, very rampant, and all the use is local. As a result, we see a lot of head and neck cancer. So about 10% of our population smoke, and like I said, they smoke the bidi, so the effect is local. About 20% of our population have smokeless tobacco. And when you add them both together, about 30% smoke and have smokeless tobacco. And this is data from all 600 districts in the country where people above the age of 15 are interviewed, habits compiled. So it's truly representative of data across the country. The Global Adult Tobacco Survey is part of a WHO initiative. So it's quality control and pretty accurate on figures of tobacco consumption within the country. And lastly, tobacco is socially accepted in our country. Here's a shot from just outside the hospital. So you see these chemists, and right next to them you'll have a kiosk that sells tobacco products. And within, say, a furlong, you'll have at least 10 kiosks like this. So it's really a way of life to consume tobacco, smoke, and chew in the country. And that really adds to the huge number of cases that we have. So how do we address this head and neck conundrum? We have certain weaknesses and obstacles, and we have certain strengths. Our weakness is stretched infrastructure and long wait time. So if someone consulted me today, typically I would give an operative date 6 to 8 weeks out for head and neck surgery, and truly that's not acceptable. We don't have very good primary care facilities for early diagnosis, so a lot of our patients present late. Socioeconomic is a problem, so there's affordability and tolerance to treatment. And lastly, there's poor compliance and follow-up. A lot of patients drop out of treatment. So those are the weaknesses and obstacles that we have. Strength is in our numbers. It allows us to publish more, better experience in operating. Some people say that maybe the numbers are your Achilles heel as well, so it's a double-edged sword. But we believe its strength is in numbers. We have institutions and manpower of repute, so a lot of quality work comes out of these few institutions that do this kind of work. Government subsidizes treatment. So at the hospital I work, 60% of my patients are treated free of cost. It's all borne by government. And we've got a great telecommunication network. People don't have a house, they don't have a permanent address, but all of them will have 1 or 2 cell phones. So that's helped us to follow our patients on trial better so that we have outcomes, and we've decreased our lost to follow-up numbers. So in our attempts, I've tried to show efforts are under 3 broad headings. How we manage the locally advanced cancers that I call T6, because they're sometimes more than the T4. Research that we've done tailored to improving outcomes, some with societal and global impact. And lastly, I'm going to give you an example of cost-effective strategies on what we do to overcome costs. So we'll see what we do for locally advanced cancers. And I've taken oral cancer as an example to drive this point home. So we recognize that oral cancer is predominantly surgical, early stage disease treated with single modality therapy, surgery or radiotherapy, and locally advanced with combined modality with surgery as the initial treatment or the prime treatment of choice. And we follow this dictum across most patients. But 20% of our patients come with lesions such as this, and I said what I call the T6 lesions. So what do we do for patients like this? If they are operable, they will undergo surgery. Here is a case in point, a patient with an extensive oromandibular defect. You can see the entire defect reconstructed with two free flaps, a fibula for the bone and an ALT for the skin and soft tissue. You can see the huge ALT in situ at the time of operation. A fairly acceptable cosmetic defect, cosmetic outcome given the magnitude of the resection. Another case in point, a free fibula with 3 osteotomies, 4 struts to make the palate, the nose, the orbit, and the zygoma, 2 skin paddles up and down, half the face resected, and again a fairly acceptable cosmetic outcome. So when choosing our patients, the criteria that we use is that the surgeon must be reasonably certain about negative margin. Good reconstruction should be feasible to ensure good quality of life. And lastly, we should use our clinical and histological judgment to say that these are biologically favorable tumors. And I've just put up the biologically favorable criteria that we use when we manage these locally advanced. The skin should have no dermal nodules or lymphedema. So this patient would typically not be operated given these dermal nodules and lymphedema. If we get a poorly differentiated or an aggressive histology, we don't operate these patients. Bulky neck nodes, even if the PET is negative, usually typically will not come for these kind of major double free flaps. And the general condition of the patient should be such that the patient can be suitable for adjuvant treatment. We looked at the results of double free flap over 2 years. There were 45 cases. Now I told you we run 5 operating rooms every day. More than nearly half our patients are oral cavity. So you can see this is a highly selected cohort of patients. And you can see nearly 2/3 of them make it through a year. So again, surgery as the prime outcome for patients with locally advanced if they fulfill the criteria that I said about them being biologically favorable. We have patients who have buccal retromolar alveolar disease situated posteriorly, and that's exactly where the patients lodge their beetle quid. Now, if you look at TNM staging, typically the masticator space is inoperable. But if you go back to your anatomy, the retromolar trigon is a few millimeters away from the masticator space. And there'll be a lot of patients who then would typically be inoperable. And I believe this staging comes from the West, where tongue cancer is very, very predominant, and masticator space in tongue is a sign of inoperability. But that's not what it is in buccal and retromolar disease. So again, in these patients, we operate some of these patients with what we call a compartmental excision, where we clear the entire infratemporal fossa. That's foramen ovale. So we take out the part of the maxilla, take the pterygoids with the plates, go all the way up to the base of the skull, and the entire compartment of the masticator space is excised. So truly in our book, these patients aren't inoperable. And this logic came from a little small Taiwanese study of 45 patients that divided the infratemporal fossa into 2 compartments, a supra-notch and an infra-notch. And the notch, a horizontal line through sigmoid notch, told us that these patients did poorly, and the ones that were infra-notch did fairly good, with outcomes worth the effort to operate these patients. And we published our results in Oral Oncology. It's just a couple of months out. 210 patients with T4 disease, 75 of them were masticator space involved. That's about a third of them. You can see that we got adequate margins in the majority. Inadequate were only in 12%. And when you look at outcomes, just under half the patients with T4B made it through, and it was worth operating these patients with compartmental resection and infratemporal infra-notch disease. So the message is that if patients are operable, surgery is the first treatment that we offer our patients. But then we have patients like this who we consider borderline resectable. We are unsure whether the surgeon would get negative margins, loose edema going all the way above the zygoma. You're really not sure if you're going to cut through disease. The disease per se looks okay, but the edema is just so much. So in these kind of patients, we use the neoadjuvant chemotherapy approach. We are mindful of the fact that neoadjuvant chemotherapy does not improve survival, but here we use it to shrink tumors that are technically unresectable, defined as the surgeon is unsure of negative margins. So probably the largest series published looking at neoadjuvant chemotherapy, 721 patients. We were able to downsize the disease in 43%, and you can see that the overall survival again was pretty good compared to those who were non-responders. So chemotherapy being used to downstage and make some of the patients with advanced cancers operable. A little innovative approach of what we do with our patients with chemotherapy. Now here's a patient point of a patient who has a buccal cancer, a lot of skin involvement. There's a gross paramandibular spread of disease. But if you look at the CT scan, there's absolutely no bone erosion. Now this patient, if you operated, technically you would have to remove the bone for margin, but the bone is not eroded. So what we do is we use neoadjuvant chemotherapy. Here's the tumor, paramandibular spread of disease that requires a segmental resection. We give neoadjuvant chemotherapy, shrink the tumor, and then operate it with conservative margins like a marginal mandible. This study has been done before in Italy, and there's a randomized trial from Lisa Licitra's group. We looked how it panned out in our kind of patients. So here is a patient who would typically be enrolled on this kind of a study, a large paramandibular spread of disease. CT shows normal bone. Here's the results post chemotherapy. So we did a phase 2 trial, a randomized trial, where the standard arm had segmental mandibulectomy followed by appropriate adjuvant treatment. The other arm had 2 cycles of neoadjuvant, reassessed, surgery followed by adjuvant treatment. Look at the profile of patients, more or less similar, but the majority of patients with this approach were gingivobuccal cancers. Look at the disease-free survival in the 2 arms, statistically not significant. So this neoadjuvant approach seemed to be safe for our patients with disease-free survival and a median follow-up of 26.5 months. Look at overall survival, exactly the same, no statistically significant difference in the 2 arms, and here is the Kaplan-Meier curve showing that they both are comparable. But here really is the punchline. In the arm that got the 2 cycles of chemotherapy, we were able to save the mandible in close to half the patients, 16 out of 34. 48% of patients had their mandible retained. Again, giving us proof that this is an innovative approach using neoadjuvant, and we are able to save some mandible. So we've now started a randomized phase 3 trial to try to address this question, and we need 600 odd patients, so it'd be a couple of years before we have a level 1 a randomized control data. We move to the second part of my talk and looking at the research we do with global impact. Now I'm happy to say that over the last 4 years at ASCO, which is the largest oncology meeting worldwide with 30,000 people who attend, our department has always had an oral presentation at ASCO with head and neck. And I think that's a feat that's even across every site. It's very rare that you'll have one department that would have it. So in 2018, oh, it doesn't show up well. My color choice wasn't good. In 2018, we did a study looking at nimuzitumab, which is like cetuximab. It's a biological agent along with chemotherapy. 27, we did 3 weekly versus weekly chemotherapy. This is published in JCO. In 2016, we did 3 treatments. 5 days a week radiotherapy, 6 days a week radiotherapy, and chemoradiotherapy. Again, looking at if 6 days could replace chemoradiotherapy, patients get treated in a shorter time and can go home much faster. And then, of course, the plenary that I did, which was a very simple study, whether we should operate the neck when it's clinically node negative for early oral cancer. And I'm going to share the data of this study very briefly because most of you all are familiar. This was a state of clinical equipoise for 5 decades, whether to operate the neck in a small oral cancer, like is shown in this photograph. There were 2 schools of thought. Some said wait and watch and do a therapeutic neck dissection, and they cited that in 2/3 of patients you're doing an unnecessary neck dissection. Those that advocated elective neck dissection said that there's better control and survival. So what we did was a very, very simple study. We screened 1,281 patients, stratified them across 4 factors, randomized 596. At the time of publication then in 2015, we had analyzed 500 because the Data and Safety Monitoring Committee at the hospital felt, looking at the event rate, that we needed to analyze our data. At that point, 243 had elective neck dissection, 253 a wait and watch approach. Look at the difference in disease-free survival. There were 81 recurrences in the elective neck dissection arm, 146 in the wait and watch, 69.5% disease-free survival if you did the neck, as opposed to 45.9 if you wait and watched, with a hazard ratio of 0.45 and a highly significant p-value. So the difference in disease-free survival was 23.5, which is close to 25%. Look at the difference in overall survival. There were 50 deaths in the elective neck dissection arm, 79 when you wait and watched, translating to a 12.5% difference in outcomes, 80% in END, 67.5 with wait and watch, again with a highly significant p-value of 0.014. Here is the forest plot, and you can see that this benefit straddles across all subsets, the stratification factors as well as aggressive histological factors known to affect outcome in this group of patients. Probably the only group was those that are less than 3 millimeters, but then as you can see, the numbers are so small and our trial wasn't powered to answer this question. And again, there's no validated method of you knowing the depth when you operate your patients or when you excise the primary upfront. And here is the multivariate analysis showing that the elective neck dissection is highly, highly significant rather than the wait and watch approach in patients with early oral cancer. What was the quality of this study? Could outcomes in the developing country have affected the outcomes? Here is the second part of the study that will now go for publication. We looked at the compliance, and as you can see, the compliance is fairly good. Those that had physical examination plus ultrasound were followed up every 2.37 months. And those that had physical examination alone were 2.39. And this is well into most guidelines that you follow your patients every 2 to 3 months. So it was not lack of follow-up that affected these results. Rather, it was the biology of the disease. Physical examination was done by senior study investigators. Anybody with an abnormal finding, I would see as well. Ultrasonography was done with high-frequency linear array transducers. And our radiologists perform more than 250 to 300 sonographies of the head and neck every month, the guys who were part of the trial, just to drive a point home that it wasn't rookie sonologists, because we know that sonography is operator dependent. And the nodal relapses, if you see, and this is an important point, that when we did the sonography, we did pick up nodal relapses quicker, about 3 months before examination itself. But it's just that the biology of the disease trumps meticulous follow-up. You can only have screening impacting on outcomes if the biology of the disease is slow. So in breast cancer, screen-detected cancers are less aggressive, they're smaller, they're hormonally positive, and they don't grow very rapidly. In a disease like head and neck, where tumor doubling time can be as low as 9 days, you cannot expect a follow-up at 2 months. You will have patients coming with adverse factors which will impact outcomes. So at the end of our study, we conclude that 1 death is prevented for every 8 patients who has an elective neck dissection, and that comes from the 12.5% difference in overall survival. And 1 recurrence is prevented for every 4 patients who has a neck dissection, and that comes from the disease-free difference of 23.6%. Fairly compelling data, making elective neck dissection the standard of care. Subsequently, there are 3 meta-analyses that corroborate this finding. I know sentinel node is very popular in this part of the world. There's some robust data by way of meta-analysis and the SENT trial. I'm sure centers within the UK were part of the SENT trial. We know 2 things about the sentinel node biopsy: high diagnostic accuracy and a very high negative predictive value, upwards of 95%. But look at the other problems with the sentinel node. There's a learning curve involved, costs involved. It's cumbersome because you have to do a nuclear or dye test. You have to serially step section your node, do an immunohistochemistry. Those that are node positive come back again for the neck dissection subsequently. Really, if you do a quick neck dissection avoiding 2B and 5, you probably don't have morbidity. So sentinel node makes a lot of sense in breast, melanoma, where extremity lymphedema can be very, very crippling. And we really will never have a trial possible because the recurrence rates are so small unless you do a non-inferiority design or you model it on shoulder dysfunction. So we're never going to have level 1 evidence to drive whether you should do a sentinel node biopsy or an elective neck dissection. So I guess if you have low volumes and you want to do the sentinel node biopsy, it's a fair thing because of high diagnostic accuracy and high negative predictive value. But for centers such as ours and other centers which are high volume, a quick neck dissection, but the neck must be treated. I'm going to leave you with a thought about the SENT trial. So 14 European centers, 415 patients with T1, T2, N0 oral cavity. Look how the patients were worked up pre-operatively on a trial setting. They had a CT and or MRI. And then depending on the size of the node and atypical features, they had plus minus an ultrasound guided FNAC in cytology. So CT plus minus MR plus minus sono and FNAC. And look at the number of nodes that were positive, 23%. So in a trial setting, if you do such aggressive workup, you still will have 23% of necks positive. And I think we've always known that the neck must be treated when the probability of metastasis is more than 20%. And that itself drives the point home that elective neck dissection should be standard of care. I come to the third part, and this is very interesting. Cost-effective strategy is something that's applicable to whichever part of the world you go to. And a very simple strategy that we use with a very strong scientific basis. And this is based on Judah Folkman's theory of anti-angiogenesis. So if you give drug, chemotherapy, frequently and at low dose, it doesn't kill the cell by direct apoptosis, but it causes sustained apoptosis of the endothelial cells. And this kind of dosing is known as meteronomic chemotherapy, after a metronome that a musician used to keep beat, like, it's hit like an orchestra uses it. So it's called metronomic chemotherapy. So let's see what low dose chemotherapy does on various cells lines, and this is cyclophosphamide. So when you look at low dose chemotherapy, these are the tumor volume for the control, conventional scheduling, and look at the low dose chemotherapy. So you have patients who have more cell death in tumor volume when you do the low dose chemotherapy. TNP, when you add, which is an anti-angiogenic factor, the cell kill is much more. Look what it does to the two types of cells. This one, the bold lines are the tumor cells, the hashed lines are endothelial cells. And you can see the amount of endothelial cells that are destroyed when you do the anti-angiogenic scheduling of chemotherapy. So low dose chemotherapy given frequently, the breast guys do it in a big way when they give treatment. They give weekly paclitaxel, and this all comes from Judah Folkman's work. So we did a phase 2 trial, again published a couple of years back, looking at patients who had conventional chemotherapy. That's arm A, which were 53 patients, and arm B is the low dose chemotherapy. And as you can see, both arms are fairly well balanced. Look at the progression-free survival. You can see that in the metronomic arm, it was 101 days as opposed to the conventional cisplatinum arm, which was 66 days. Exactly the same for overall survival, 249 and 152. So metronomic seems to be scoring a cost-effective strategy for patients with advanced cancers. Most importantly, toxicity, negligible in the metronomic arm. You can see the nausea, vomiting, hyponatremia, much higher when you give conventional chemotherapy. I extrapolate this to the cetuximab trial in the same set of patients with advanced cancers. Cetuximab, in my understanding, is not approved by NICE in this country. But look at the cetuximab design. It was supposed to be the first study that showed an improvement in overall survival in head and neck in 35 years when it was presented at ASCO and subsequently published in the New England. So one arm got standard chemotherapy for 6 weeks. The other arm got standard chemotherapy plus cetuximab and weekly cetuximab, and they showed a difference in survival of 3 months. Clearly, this arm got more treatment than this arm, and now we have level 1 evidence, and it costs quite a lot to treat these patients with cetuximab. I just wonder if they had done the metronomic dosing on this arm, whether there would have been any difference in this outcome. So at our center, we use the approach of metronomic because many of our patients don't afford cetuximab in this setting, particularly when it's end-stage disease, 10 months survival, and we've now again started a phase 3 trial to see whether this approach would be superior in terms of outcomes as well as in terms of costs. So over the last half an hour, I've tried to give you 3 examples of how we treat advanced cancers, how we innovate, we do various types of researches that will have a global impact, and various cost-effective strategies that we employ. And I think that's been our mission as we treat the huge number of patients that we have with head and neck cancer. Thank you once again for the attention and the privilege of the Simon Lecture. Thank you very, very much.
I'm sure you'll agree, a humbling lecture, a tour de force. There are very few papers that really influence us almost every week in the MDT. Most of those are by oncologists. To have a paper from a surgical unit from Tata Memorial that influences this in really almost all our MDTs, when to to operate on the neck is just a fabulous bit of work. And so thank you very much for the lecture.
Thanks,
and
Peter.
please
Thank you.
accept a
Thank you
medal
so much.
on our behalf. Thank you.
Thank you.